Okay, so insyaAllah hari ni dengar clear kan? Ke ada? Jelas, okay. So hari ni kita akan ada session patutnya backside teaching kan ni?
Dia tapi tak dapat.
Okay, so tak apa. So today basically more to macam backside teaching je backside teaching, tapi yang virtual punya backside teaching kan. So saya repeat the ILOs. So the learning objective of today are first, how to differentiate cyanotic versus acyanotic heart disease based on history, PE and also generally lah. And then second, how to differentiate between ductal dependent and non-ductal dependent. And third, management of hypercyanotic spell. Number 4, scars for different heart operation. And number 5 is important syndrome associated with heart disease. Okay, sekejap ni. Okay. So, kita boleh start kan? Semua dah ada kan?
Dah ada dah.
Okay, sekejap. Okay. Slides. Okay, so you guys boleh present kot? Okay, so how we are going to run the session today is you guys going to present. Okay, you guys going to present, and then I will add on a bit, and we can discuss. Any question you can always ask the presenter and also myself. And then we can go about it, how to go about it, nanti kita tengok lah. While running the session, nanti kita add lah apa-apa. Okay, so presentation ni saya tekan
Saya boleh je prepare Doktor.
Okay.
Saya present je.
Okay, okay.
Okay.
Prepare and then awak control lah the thingy.
Okay.
Okay, boleh start lah.
Alright. Saya buka kejap Korang nampak
Nampak je.
Nampak
Nampak.
So, mana tadi?
Getah.
Okay, so this is the presentation. I will pass to the first presenter.
Okay.
First presenter, Zira kan?
Yes. Okay, so this is
Articulation by Azira.
okay. Okay, so boleh present lah. Azira.
Azira, Azira.
Kuat sikit je.
Kuat sikit je.
Okay. Okay, di meantime semua silent mic, off mic tu. Sementara Azira present, kita off mic. Siapa yang ada question boleh tanya. Okay. Tanya Azira.
Okay.
Okay. So Azira, cuba explain the fetal circulation.
Assalamualaikum. Can you hear me?
Okay, can.
Okay. Bismillahirrahmanirrahim.
Sajrah, dia putus-putus saja.
My name is Hadira and I
Okay.
this exchange provide the gas exchange. Putus ya. Sekejap saya tukar pakai phone lah.
Okay. Okay, boleh. Sementara tu saya ada benda sekejap. Try.
Hello.
Okay.
Clear dah?
Okay, good.
Hello, dengar tak?
Dengar.
Clear.
Dengar. Sajrah boleh present. Sajrah boleh present lah.
Hello.
Present lah.
Okay. I'll start from the beginning again. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So today I'll present about the fetal circulation. First, we have to know about the differences between the fetal circulation and also the newborn or adult circulation. So in fetus, instead of the lungs, the placenta plays the role for the gas exchange and also for the nutrients to the fetus. So the lungs do not provide the gas exchange. So, the pulmonary vessels will be vasoconstricted, diverting the blood away from the pulmonary circulation. So the placenta is the most important part in playing the role in gas exchange. So there are three cardiovascular structures in the fetus, unique to the fetus, in which there are ductus venosus, foramen ovale, and also ductus arteriosus. These three structures act as shunts, in which they will divert the blood and bypass the lungs and the liver. Okay, so the placenta is not as efficient as the lungs in functioning as the gas exchange organ. Okay, so the PO2 from the umbilical vein, which is umbilical vein will bring the oxygenated blood from the placenta to the fetus, right? So the PO2 in the umbilical vein is around 30 to 35 millimeter mercury only. So why it is called umbilical vein? Even though it brings the oxygenated blood, right? So why it is called vein? Because everything that goes into the heart is called vein, and everything that comes out from the heart is called artery. So umbilical vein brings the oxygenated blood to the heart, right? So it is called umbilical vein. So 50% of the umbilical venous blood will enter the hepatic circulation, and the rest of the blood will bypass the liver via the ductus venosus to the inferior vena cava. So the inferior vena cava brings the poorly oxygenated blood from the lower limbs. So then the poorly oxygenated blood will mix with the blood from the umbilical vein via the ductus venosus, right? So at this point of time, when it is combined, the PO2 is only around 26 to 28 millimeter mercury. So this combined blood from the inferior vena cava will go into the right atrium, and then in the right atrium it will pass through the foramen ovale to the left atrium instead of going to the right ventricle. Why? Because in the right atrial inferior vena cava junction, there is a flap of tissue. We call it as um, eustachian valve. Okay, this eustachian valve um, makes the blood from the right atrium, from the inferior vena cava, goes straight to the foramen ovale to the left atrium. So the blood in the left atrium will go through the mitral valve to the left ventricle, and the left ventricular blood will be ejected to the ascending aorta, and then in the ascending aorta, the blood will be supplied to the brain and also the upper part of the fetal body. Okay, after the blood circulating in the brain and also the upper part of the fetal body, it will come back to the superior vena cava. So after it supplies all the upper part of the fetal body and also the brain. So the blood will be less oxygenated, right? The PO2 at this point of time is around 12 to 14 millimeter mercury. So the less oxygenated blood in the superior vena cava will then enter the right atrium, and it will preferentially flows across the tricuspid valve into the right ventricle rather than going to the foramen ovale. It will cross the tricuspid valve into the right ventricle, and then from the right ventricle it will be ejected to the pulmonary artery. Okay, in the pulmonary artery, only 5% will be will flow into the lungs. Why? Because the pulmonary circulation, just now I mentioned that it is vasoconstricted, right? So only 5% will go into the lung, and the major of it will go into via the ductus arteriosus into the descending aorta, and then from the descending aorta, it will supply the lower part of the body, and also some of it will go to the two umbilical arteries into the placenta, and then in the placenta, the carbon dioxide and waste products will be released to the maternal circulation. So can you understand what I have explained just now?
Yes. Yes, yes, good, good, very good. Okay, everyone
Sorry,
tune in about the
I
explanation.
couldn't.
Anyone got any question ke before I start to ask? Okay, good.
Explanation by Hazira just now. She mentioned that after the shunting from the right atrium into the left atrium via the ovale and then into the left ventricle and then into the systemic circulation, then my question would be that why does it circulate into the upper part of the body first? I mean, I thought that as long as it passed through into the aortic arch, it can go both upper and also lower.
Azira?
Um, as far as I read from the Nelson, the it says that the upper part of the body is mainly supplied by the left ventricle, meaning that from the ascending aorta, and then it will supply the upper part of the body and also the brain. And then from the right ventricle, it will supply the lower part of the body, meaning that from the right ventricle and then to this descending aorta via the ductus arteriosus, then it will supply the lower part of the body. But I'm not sure why.
It's actually just the preference of the blood flow. Because if you look at the diagram kan, actually not all the blood from the inferior vena cava will pass through foramen ovale to the I mean to the I mean go up to the through the ascending aorta, because some of it will actually goes down through the into the right ventricle, but most proportion of it will go through the foramen ovale, similar to the superior vena cava. So blood from superior vena cava, not all will actually goes to through the tricuspid valve, through the uh tricuspid valve, yeah, tricuspid valve down to the right ventricle, because some of it will actually goes into the foramen ovale as well. Tapi mainly predominantly will go down to right ventricle. From superior vena cava will go down to right ventricle, and from inferior vena cava will go to the aorta. Will go to the left side and go to the aorta. Similar to the blood from the aorta, blood from the pulmonary, blood that's come from the right ventricle. Only 5% go to the lung kan. The rest go
Yes.
to the left side. The left go to the left side through the ductus atriosus kan. But still got
Yes.
5% akan pergi kat lung. So but
Mm.
predominantly akan supply the lower limb via the ductus atriosus. Okay, from okay. So in general, the two non-functioning organ atau less functioning organ in fetal circulation is liver and also lung. Okay, because these two roles are played by the placenta. Okay, that's why liver punya portal circulation are not well developed in fetus. Okay, it will develop after the the ductus venosus uh, constricted, and of and also after the ductus atriosus constricted. Okay. Okay, this is mainly because of the pressure lah. Because in fetal circulation, the pressure in the lung, intravascular pressure in the lung, intrapulmonary pressure, and also intravascular pressure in the lung is very high because lung is collapsed. Okay, the lung is collapsed, so do the vessels in the lung. So the pressure is high. That's why blood prefer to go up instead of to go to the lung circulation through the ascending aorta and goes up to the branches of the aorta. And also, so do the portal circulation is very high pressure, high resistance. So most of the blood will go through the ductus venosus instead of entering the portal circulation. Okay kan? Faham kan? Okay, any more question?
Thank you, Doctor.
Go to the second slide.
Doctor, I would like to ask,
Huh.
just now Azira mentioned some about a structure that
Hmm.
affects the blood flow, whether the blood flow goes to the foramen ovale or to the right ventricle, which is, I think,
Eustachian
eustachian flap.
valve.
Um, is it
Station valve.
eustachian valve? Is it the same as crista dividends or is something different?
That's a good question.
I'm not sure about that. Sorry.
I'm not sure about crystal dividends as well. What is crystal
The,
dividend?
ada I read macam dari nurse something about it divides the flow for the foramen ovale and the right ventricle, but I'm not that sure.
Okay, let me see. Crystal dividend. Uh, I think it's the same.
The same.
It's the
Oh,
same. It's the same. It's actually crystal dividend is like it works like a valve lah, valve to make sure the flow is actually one way to the into the foramen ovale.
oh, okay. Thank you, doctor.
And this valve actually, and this valve eustachian valve of crystal what you call it, dividends ni, is actually later on, okay, it will become the right atrial appendage. Okay, the tissue will remain there, will remain there. However, the foramen ovale will close now, will close, but the tissue will remain there. And that is how when doing echo, you have to identify the structure to determine
Mm.
the right which one is the right atrium. Remember when you do the definition of right atrium, left atrium, or right ventricle, left ventricle is not depending on the position now. It's depending on the structure and anatomical.
Mm.
So right atrium can be at the left side, but it's still a right atrium. Faham? So do left ventricle, it can be on the left side, on the right side, but it's still anatomically and structurally it is a left atrium. So we define atrium left or right. It's not based on the position, it's based on the anatomical and structure. Faham tak? That's why we've got TGA. Kan TGA. TGA because it's transposition of great arteries. You also got CCTGA ataupun the previous name was called LTGA. TGA ada dua. So you've got DTGA or LTGA and LTGA ataupun TGA and CCTGA. CCTGA is congenitally corrected TGA, which mean it is a TGA. The great arteries are transposed, but so do the ventricle. The ventricle also transpose to each other. So the left ventricle move to the right side. So the right side move to the left side. So the net effect is become normal lah. The heart looks normal. I mean the left side, the left ventricle will supply the aorta. The right ventricle will supply the pulmonary artery. Faham tak? Tapi when you look at the heart, I mean from just look at the diagram, you will see, oh, this is left ventricle, this is right ventricle. But the function is different. You have to determine because the the label the labeling of left and right ventricle is not by the position, is actually by the anatomical and function and also structure of the knee. So it's important to recognize the appendage, right atrium appendage, to determine where is the location of the atrium, whether the atrium is right, this is right atrium or this is left atrium. Because a lot of case, especially in complex, not a lot lah, there's some rare case of complex cyanotic heart disease or complex heart disease where there is a transposition of the atrium and also transposition of the left atrium, left ventricle of the ventricle. So which means the right atrium is actually at the left is actually at the right. Macam dextrocardia lah, dextrocardia. Okay, dextrocardia. If you look at dextrocardia, they've got two atrium, two ventricle as well. But the left ventricle is actually at the right side and vice versa. Okay, faham kan?
Yes, sir.
Okay, got any more question ke?
Thank you, sir.
Okay, we can move to the next slide. Okay, next slide, please.
Thank you, Doctor.
Okay, don't worry. This is a good one. Okay. Crystal evidence.
Assalamualaikum warahmatullahi wabarakatuh. Sekejap. Sorry, I'm a bit confused. Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Jazli. I'll be presenting about the fetal adaptation for fetal circulation adaptation when it becomes a newborn. Okay, as my colleague have explained just now regarding the fetal circulation, we know that it starts before birth. The pathway is mainly from the placenta through the umbilical vein, and we know that most, if not all, of the blood from the umbilical vein will go through the ductus venosus. As it goes through the ductus venosus, as you can see the color here, the color also signifies the oxygen concentration. You can see highly oxygenated blood. It mixes with the less with this deoxygenated blood, so there's a mixing of both. That's why it becomes a bit diluted, and it empties into the right atrium. So it flows here through the ductus venosus because they will face resistance in the hepatic circulation, as mentioned previously by Hazira, and then it empties into the right atrium. As it empties into the right atrium, this one is in fetal punya circulation lagi as it empties into the right atrium, about 1/3 of the blood flow will go through the foramen ovale, whereas 2/3 of the blood will go into the right ventricle, which accounts about 65% of the volume, of the blood volume. It enters the right ventricle. So as it goes, we will follow through the pathway from the right ventricle, yeah. So from the right ventricle, it will pump, as mentioned previously, and then it will go through the pulmonary artery. So I would like first to stress about the pulmonary artery. So as mentioned, as a doctor mentioned previously, that in the pulmonary vasculature, there is high resistance. Why does that happen? Because as you can see here, during the fetal period, there is a lot of fluid inside the alveolus. When there is a lot of fluid inside the alveolus, there is low oxygen concentration, which result to a vasoconstriction. This reaction, this reflex is called hypoxic pulmonary vasoconstriction. Okay, hypoxic pulmonary vasoconstriction. Why does that happen? Okay, from my understanding, why does that happen? The main reason what they want to do, what the body wants to achieve is to get the best oxygenation for each of the red blood cell. So to make that happen, because you already have limited number of oxygen, so you want to make as little as possible of red blood cell flow so that you can get a lot of oxygenation per red blood cell. Because let's imagine if we have limited oxygen and then there's a lot of blood flow, there will be a lot of red blood cell that's unable to be oxygenated. Do you guys understand?
Yes.
Some, okay,
The rest of
so
it from
yes, doctor?
other people, the rest you guys understand kan? It's a very important concept because later we will learn about PPHN, I mean persistent pulmonary hypertension in newborn. So this is very very important concept. Understand kan? Semua. Okay.
Okay. Alright, so this causes mana dia? This causes the vasoconstriction. So, but when there is normal alveolus, later on I will explain the differences. So this one is during the fetal period. Okay. So because of that,
Sorry, Jess.
yeah.
I would like to ask. Uh, why there is a hypocephalus just now? I think I just
Inside
terlepas.
why is that?
Why hypocephalus tadi?
Dia hypoxic because during the fetal period there's a lot of fluid inside the alveolus. Because the alveolus, the fluid still retained inside the alveolus. But later on, when it achieve newborn period, there will be changes lah, which I will explain later on. Okay. So because of this concept, there's a lot of high pressure pulmonary vasculature. So it makes very difficult for blood flow to enter to the pulmonary vasculature. Hence, only about 8 to 10%, based on 8 to 10% enters the pulmonary vasculature. But more than 80 to 90% will bypass the pulmonary vasculature through the ductus arteriosus. So as you can see, actually in fetal circulation, there's only two ductus je. One ductus venosus, which is from the going to the heart, ductus arteriosus going away from the heart. So in the ductus arteriosus, about 80 to 90% blood flow when compared to the blood flow to the pulmonary vasculature, which is about 8 to 10%. So as it goes through the aorta, and then it supplies the whole body. And as it supplies the whole body, it later go back through the umbilical arteries, to remove the waste and re-oxygenate back for fetal circulation. So that's the main concept. So we settle about the flow from the right ventricle. From the flow for the foramen ovale is rather similar. You go for the 1/3 of flow from the right atrium, go to the foramen ovale, it later go into the left ventricle and is pumped. But most of it still from the ductus arteriosus lah. Okay, so that's fetal circulation. Now let's focus on what happens after the newborn. So when there's birth, there's a lot of changes that we have to take into account. But the key points here that we need to take into account is the changes that happens at the ductus venosus, ductus arteriosus, at the foramen ovale, and at the umbilical veins and artery. So as the child is being born, there is the key change happens when there is clamping. Okay, why is that a key feature? Because once there is clamping, you reverse the whole circulation. In a sense, you reverse the whole pressure gradient. Previously, during the fetal circulation, the pressure gradient here is rather low, which facilitates blood flow, whereas at the pulmonary vasculature is high, which makes blood to go through the ductus flow instead. But when you do clamping, what happens is that you increase the pressure. It's like you do an extreme measure of vasoconstriction. You clamp. Because of the clamping, okay, because of the clamping, there will be minimal flow from the umbilical vein, so it is reduced. Reduce minimal flow to umbilical vein, and it later flow through the IVC. So as the blood flow is reduced, it affects oxygenation. So focusing on the ductus venosus first, as there's a reduction in blood flow, there is a cause of lower oxygenation and lower supply of prostaglandin from the placenta. As the placenta is cut off or is flow is limited by the clamping, so there is a reduction in there is a reduced oxygenation. Okay. Basically, the prostaglandin makes the ductus patent. So as the the placenta is removed from the circulation, so it make the ductus venosus less patent. So they will tend to fibrose and close, which cause blood flow to go through the portal vein instead. And as it goes into the circulation and into the right atrium, as mentioned previously, as you can see here, as it goes and there's a crista dividens which divides into the left atrium and through the right atrium. You can see it goes into the foramen ovale, but most of it will go into the pulmonary vasculature. So let's focus on the pulmonary vasculature. So the second most important change is the change of from a very high pressure in the pulmonary vasculature into low pressure. How does it happen? So once the fetal circulation, once the fetal start to take the first breath of air, which you don't need much, you just need about a 5 to 10 milli water pressure of oxygenation to make the alveolus patent and open. So once that happen, it causes vasodilation based on the principle that have been mentioned previously. Because there's increased oxygenation, so there is no hypoxemic pulmonary vasoconstriction, so it's vasodilated. As it's vasodilated, there will be reduced in pressure. Due to the reduce in pressure, so because there's reduced in pressure, the flow would be easier, would be for flow of the pulmonary artery. So the pulmonary artery tends to flow easier. As it flows easier, it enters the lungs more compared to the flow through the ductus arteriosus. Okay, as it flows more there, the ductus arteriosus also is reduced in patency because of the cut, because it is the source of prostaglandin is cut off, and because of the higher oxygenation. So the higher oxygenation causes the ductus arteriosus to close lah. Okay, mana tadi? So ini close, more blood flow. As there's more blood flow to the pulmonary artery, there will be more blood flow to the pulmonary vein. As there will be more blood flow to the pulmonary vein into the left atrium, it causes higher pressure. Due to the higher pressure from the left atrium, it will push the foramen ovale to the close because of the higher pressure at the left atrium when compared to the pressure to the right atrium. This does not happen prior to given being born lah. Okay, so that's the changes, and then the blood flow goes through the umbilical arteries and it returns into the circulation. So on top of that, okay, tak apa. Okay, so that's the main changes we can see. So overall, what happened during this process, the ductus will close due to the cut off from the prostaglandin, and then cut off prostaglandin source from the placenta, and then the flow would increase to the lung, and the ovale would be closed. So in certain cases, there will be pathological issues with fetal adaptation to newborn, which is mainly, one is transient tachypnea of newborn. And how does that happen? It happens because there is not enough of the fluid is being extravasated outside, meaning after newborn, supposedly you will have a normal alveolus. But in a transient tachypnea of newborn, there is not enough of the fluid from the alveolus going up. So there will be some retainment of the fluid inside the alveolus, which cause the transient tachypnea of the newborn. Apart from that, there is also other pathology which is associated with prematurity, which is called persistent pulmonary hypertension of newborn, which is a result of a persistent increase in pulmonary vasculature because of extensive hypoxemia, acidosis, among other factors that can cause a persistent increase in pulmonary vasculature. Okay, I think that's it. And last point we can add is that some in ductus arteriosus, functionally it closes within 1 day roughly, but in anatomically for it to permanently close, it takes about 1 week because you will need time for all the fibrosis to happen, all the fibrosis to permanently close the ductus arteriosus. But functionally, it closes about 1 day period. Okay, I think that's all.
Good. Any question you guys want to ask?
I'm sorry, Leslie. I was quite unclear earlier. What caused the left atrial pressure to increase and close the foramen ovale?
Okay, so the good question. So the issue is because in fetal circulation, there is minimal blood flow to the pulmonary circulation. Mentioned it was about 8 to 10% based on Nelson. But when the baby is born, there is extensive vasodilation due to the baby crying and air entry into the alveolus and the fluid is extravasated. There's vasodilation. So there is massive blood flow into the pulmonary artery. When there's massive blood flow to the pulmonary artery, we can say relatively there's massive blood flow to the pulmonary vein. When there's massive blood flow to the pulmonary vein, there is significant increase in left atrium punya pressure. So when there's increase in the left atrium punya pressure, it will push the patent foramen ovale, the foramen ovale, towards the right atrium because of the difference in pressure, which is the left atrium higher than the right. So it pushes the ovale to close.
Okay. Okay, thank you.
Okay.
So I want to highlight a few important things that will be useful later lah in our series today. So one is the role of prostaglandin. Okay, the prostaglandin is actually produced by the mother. Okay, mother will produce prostaglandin, and prostaglandin will enter the fetal secretion through the placenta lah. Okay, the role of prostaglandin is to maintain the patency of the ductus, and to maintain the patency of the ductus atrocis and also ductus venosus. So when we clamp the umbilicus, so there is reduced in the supply of prostaglandin. This is one of the contributing factors that actually leads to the constriction of the ductus atrocis and also ductus venosus. Okay, that's why in patient with ductal dependent lesion, we give them, what is the treatment?
Prostaglandin.
Immediate prostaglandin.
We give PGE1. So we give prostaglandin. Okay. So prostaglandin has the ability to dilate the vessels. Okay. Itulah, yang itulah yang the rest I think just covered most of it. Any more question before we proceed to the next presentation? Okay, tak ada kan? So next is okay, next presentation apa?
Hello, Assalamualaikum. Assalamualaikum Doktor and my fellow friends. So my name is Zafira. Actually just my slide is actually have 8 pictures.
Oh, yeah.
I do it as an animation. Okay, I think
Okay, tak apa cik.
just
Nanti saya
just boleh just ada you can you take from the Telegram
okay.
the original one from me?
Original one. Okay, alright. Okay.
That's right.
Any stuff?
Yes, but you turn it to the presentation slideshow.
Okay. Sebab Muncul mention ada animation. Aku tak tahu kau punya ada animation. Okay. Right.
Oh, sorry,
So, jadi
lupa.
slide tu.
Yes.
Jadi slide. Okay.
Okay. So, Assalamualaikum. So, Bismillahirrahmanirrahim. So, I will present on the cyanotic congenital heart disease. That's what I have to find. So, I will ask, so what is cyanotic congenital heart disease? It occurs when some of the systemic venous returns cross from the right side of the heart into the left side of the heart and then goes into the aorta. It is called right to left shunt. So that's for cyanotic congenital heart disease. Just tekan. So the cyanotic congenital heart disease can be divided into to two, which is decreased pulmonary blood flow, and then the second one is increased pulmonary blood flow. So the example of decreased pulmonary blood flow is tetralogy of Fallot's, pulmonary atresia, tracheostomy atresia, transposition of pre-arteries. And the increased pulmonary blood flow The example is transposition of great arteries, total anomalous pulmonary venous return, truncus atrocis, and hypoplastic left heart syndromes. So why it is called decreased pulmonary blood flow? It is called because of the blood flow from the heart into the pulmonary, and it is decreased. However, the increase the vice versa lah. So next slide. So the first one, I will explain on the tetralogy of Fallot and the decreased pulmonary blood flow. So what is tetralogy of Fallot? So tetralogy of Fallot, you can, from the name itself, it is tetralogy. So there is 4 cardinal features that we need to remember. Which first is the pulmonary stenosis, which usually occurs as subvalvular or infradibular obstruction. And then the second one is a ventricular septal defect, usually large, VSD. And then the next one is overriding aorta. And the last one is right ventricular hypertrophy. So these 4 cardinal features is important to remember for the tetralogy of Fallot. So so the overriding aorta, you can see from the pictures, the overriding aorta is mean by the aorta is positioned over the ventricular septal defect itself. So the blood mix there at the below the aorta and goes into the aorta. So the circulation is basically from the superior vena cava and inferior vena cava into the right atrium and goes into the right ventricles. And some of the blood from the right ventricle goes into the pulmonary artery. However, because of pulmonary stenosis, so there is less blood goes into the pulmonary artery. So most of it goes into the shunt into the right, shunt into the left side of the heart. And then the blood from the pulmonaries really goes into the pulmonary veins and goes into the left atrium, left ventricles, and then goes into the aorta. And those goes into the aorta is a mixing of the both from the deoxygenated blood and oxygenated blood from the vein. So usually the presentation of tetralogy of Fallot is later. And the acute one is usually occurs with cyanotic spells. So that's for tetralogy of Fallot, the physiology of tetralogy of Fallot. So the next one, under decreased pulmonary blood flow, next is pulmonary atresia. So pulmonary atresia, it is about where the pulmonary valve itself has been fused into the membranes. There was no pulmonary valve. So the blood from the right atrium and goes into the right ventricle. So the blood cannot go into the pulmonary artery because of the pulmonary valve is absent. So the blood will regurgitate back from the right ventricles into the right atrium, and then that's why all of the blood from the right side of the heart goes into the left side of the heart via the foramen ovale. So at the left side of the heart, so there will be mixing of the deoxygenated blood and the mixing of the oxygenated blood and deoxygenated blood. So where the patient get the oxygenated blood from this kind of defect? So the deoxygenated blood come from the patent ductus atrocis. Why? Because the left side, the blood flow from the left side of the heart, we goes into the aorta, and then there is a patent ductus atrocis there. So some of the blood will goes into the pulmonary artery and goes into the lungs and pulmonary veins and enter the oxygenated blood into the pulmonary arteries, into the left atrium, and then there is mixing there. So that's why this patient, this baby will get cyanosis because of the mixing of the blood. So the pulmonary atresia is actually, I think, is a doctor dependent congenital heart disease. So if there is no doctor, there's no docs, especially the PDA. So the baby will not stay. The baby may die within first week of life. So that's it for the pulmonary atresia. So next is tricuspid atresia. So tricuspid atresia, from the word atresia, like I have mentioned before, tricuspid atresia is due to absence of the valve itself. So from this picture, there is absence of tricuspid valve. So when there is absence of tricuspid valve, so the blood flow from the superior and inferior vena cava will goes into the right atrium, and then goes straight towards the left atrium, and then the left atrium. So there will be mixing at the left atrium between the deoxygenated blood and the oxygenated blood. So the blood from the left atrium will goes into the left ventricle, and then blood from the left ventricle we goes both into the aorta and the pulmonary artery. So some of the blood that came into the left atrium will be oxygenated, and then there will be mixing of the blood. And then the baby becomes sinus lah. So that's why in this tricuspid atresia, it is also doctor dependent because especially at the atrial level, we want the mixing of the right atrium, the blood from the right atrium and the left atrium. If there is no 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 connection between this right sided and left sided, so this patient also had not incompatible with life lah. So the so that's it for the tricuspid atresia. So next is TGA ataupun transposition of great arteries. However, transposition of great arteries can be both either decrease pulmonary blood flow or increase pulmonary blood flow. So the TGA that under decreased pulmonary blood flow is when there is evidence of pulmonary stenosis. Like I have said before, when there is pulmonary stenosis, so the less blood flow from the arteries from the ventricles atau from the heart into the pulmonary. So so I will explain first about the TGA. What is transposition of great arteries? Usually in normal patient or in normal baby, the aorta or the pulmonary artery will arise from the right ventricle and the aorta will arise from the left ventricle. However, in this patient we have TGA, it is opposed, whereby the aorta is arise from the right ventricle and the pulmonary artery will arise from the left ventricle. So the blood flow from the right atrial, which is deoxygenated blood, will goes into the right ventricle and goes straight into the aorta without oxygen. Whereby from the blood flow from the pulmonary artery and goes into the pulmonary vein and left atrium, which is oxygenated, will go back into the pulmonary artery. So there is macam not a good circulation. However, this not a good circulation lah. So that's why they must be for the patient to stay alive. So they may the baby or the heart must have connection either in the ventricular septal defect or from the atrial part or ventricular part. So in this picture, the connection is between at the atrial level, whereby the blood from the left atrium mix with the oxygenated blood from the right atrium, and those blood will mix into the right ventricle and goes into the aorta. So the blood no, the blood that goes to aorta is more sinus lah. And then goes into the body. So this patient will come in with cyanotic. Cyanotic congenital heart disease, sinus. So it is also doctor dependent. And so the next one, so this is basically the principle of the physiology of the transposition of great arteries. So next is total anomalous pulmonary venous return. What is total anomalous pulmonary venous return? So you can see from this picture. Okay, you can see that usually in normal baby, the pulmonary vein is connected to the left atrium. However, in this patient with total anomalous pulmonary venous return, the pulmonary vein is connected not into the left atrium. It connected dia either supracardiac or infracardiac. So this patient, this picture is about the supracardiac because the supracardiac is more common compared to infracardiac. So the supracardiac, the pulmonary vein will be connected into the such as left brachiocephalic vein like that. If the infracardiac, so we will connect with the ductus venosus or portal vein. So in this picture is the pulmonary into the brachiocephalic vein and goes into the SBC. So the physiologically is the blood flow from the superior and inferior vena cava. So the blood flow from the lungs goes into the pulmonary vein is the oxygenated one. So the oxygenated one will combine with the deoxygenated one into the right atrium. So there is mixing of the both blood into the right atrium. So the blood from this picture, so there must be a defect over the from this picture lah. There is a defect on the arterial level from the right atrium into the left atrium, so that the mixing the blood can go into the aorta to supply the systemic to supply the body tissues. And some of the blood will go also into the right ventricle and pulmonary artery to be oxygenated. So, however, the return of the the return of the blood from the pulmonary vein, from the lungs to the pulmonary vein is into the right atrium lah. So they must be mixing to make this patient or this baby to stay alive. And then NSAD mentioned that usually the arterial level communication is macam important lah compared to ventricle. So that's for the total anomalous pulmonary venous return. And then the next one is truncus arteriosus. So what is truncus arteriosus? It is there is combination, or I can say it's combination between the aorta and pulmonary artery. From this picture, you can see both the blood from the left ventricle and right ventricle both goes into the one single trunk, and those trunks will be divided into aorta and pulmonary artery. So that's why this patient will have sinus lah. So will be sinus. So and then I think that is for the truncus arteriosus lah. And then the last one is the hypoplastic left heart syndrome. So the hypoplastic left heart syndrome, it is Idea from this picture, the in definition is the failure of development of the mitral or aortic valve. However, in this picture is there is this absence of the aortic valve. So the blood from the left ventricle, which is oxygenated, cannot go into the aorta to supply the system to supply the body tissues. So um, so that's why the oxygenated blood from the left atrium will uh, will goes into because of high pressure there. So will goes into the right atrium and mix with the deoxygenated blood and both goes to the right ventricle and goes into pulmonary artery. So when so this hypoplastic left heart syndrome needs some that actually needs some connection which is patent arteriosus to make the blood flow into the aorta. If no pulmonary patent arteriosus, so there's no blood can goes into the aorta. So no supply of the body, no supply of uh, oxygen into the body. So hmm. So I forgot to mention when will we when will say this patient had cyanosis. The cyanosis present when there is more than 4 gram per deciliter of deoxygenated blood. Uh, no, 4 gram of deciliter of hemoglobin in the oxygenated blood. Hmm.
No, it's actually more than
So
3 gram, 3 or
more
4 lah,
than
on reference.
uh,
More than 3 or 4 gram of per deciliter of hemoglobin that is deoxygenated. For example, for example, if my HB is 15, only 12 of my HB is oxygenated. Okay, the rest of the other 3 gram is not oxygenated, then I'll be sinus. Faham tak? So those the more hemoglobin that is not oxygenated, then the more sinus the child will be. Okay, faham kan? Okay, got question lah. This is very lengthy one. Got any question? And this is very important. This is the overview of cyanotic heart disease. Okay, ada question tak?
With regards to the transpositions of great artery, my question would be with relation to the L, which is the congenitally corrected TGA. My question would be that actually I'm confused because in Nelson mentioned that there will be some ECG changes, in particular the abnormal P wave, absence of Q wave in V6, pathological Q wave in LED3, AVR, and AVF, and also an upright T wave across the precordium. My question would be that I cannot understand why this manifestation occur. The ECG changes, abnormal P wave, pathological Q wave, in LED3, AVR, and AVF, and then another one will be the upright T wave across the precordial lead.
Hmm. That's quite difficult question. Can you show us the picture, the image of TGA? Just okay, look at TGA. Okay, ni TGA kan. Okay. So first you have to understand. Okay. In TGA, there's two type. As you mentioned correctly, D and L TGA lah. L TGA now we call as CT TGA. Congenitally corrected TGA. Okay, so in TGA, what happened is the right ventricle is supplying the aorta, and the left ventricle is supplying the pulmonary artery. This is DTGA. This is the abnormal TGA lah, the original TGA. In your question, CCTGA means the right and left also switch. The right ventricle and left ventricle is also switch. So what happened is the left ventricle will supply the aorta, both switch. So what happened is Uh, Alwi. This one is actually this is okay. In congenitally corrected is actually this is what John OA. This one is CCTGA because I think this diagram is a bit weird lah. Jap. Because in TGA, oh, okay. Because the diagram is okay. Okay lah. So in general lah, in TGA kan, in TGA, what happened is the right ventricle, as I mentioned, the determinants of right or left is based on the function and anatomy of the ventricle kan. So right ventricle has a weak muscle. Okay, remember right ventricle has a weak muscle, and the function is actually just to pump blood to low pressure pulmonary circulation. Faham kan? So right ventricle, the function is weak because its only function is to pump blood to the low pressure pulmonary circulation. Okay. While the left ventricle, its main function is actually to push blood against the high pressure systemic circulation. So it has a very strong muscle lah. Your left ventricle has strong muscle. That's why when you did echo, in order to determine this is right or left ventricle, you look at the muscle. You look at the muscle bulk, the hypertrophy of the trophicity of the muscle, and also look at the valve lah, mitral valve, and also the tricuspid valve. Okay. So what happened in LTG? Sekejap. Sekejap, I tengok dia tak gambar dia. Sekejap. Sekejap. Sekejap cek gambar jom. Kalau ada gambar senang sikit. Sekejap. Tak nak tunjuk. Tak apalah, you guys carilah gambar. You guys cari gambar in, while listening to what I'm speaking. Google yourself lah CCTGA atau LTGA. So in CCTGA, okay, initially the TGA first the TGA is transposition of great arteries. Okay, originally, I mean in fetal circulation, actually the PA, even though it's rise from the right ventricle kan, tapi dia macam ni, dia pusing tau. So look at this picture on the screen kan. So sepatutnya the pulmonary valve is on the right side. So the originally it is actually transposed. I mean the PA is actually on top of your aorta. They're on top of aorta. So both, if you look at from the front, you will only see like one vessel because aorta is actually at the back of your pulmonary artery. But in transposition of great arteries, both become parallel. So that's why you see a widened mediastinum. Or not? In TGA, from axial you will see like widened mediastinum. Uh, you will see, sorry, you will see egg on the string because because the from X-ray, because X-ray is AP kan, AP. So you will see like the PA and AO is on one plane. Tapi it's actually side by side. Because the heart kan, dia bukannya duduk. Alah, susah lah macam ni. The your heart is actually dia turn a bit tau. Dia bukannya flat. Because when you look at the X-ray, the first the top of the heart on the X-ray is actually the what? The RV kan. You bukannya nampak. Kalau lah heart ni actually kalau heart macam ni kan, then you should see RV and LV the same size kan. Tapi when you look at X-ray, the top of the heart is actually the RV. You cuma nampak RV je, sikit je LV you nampak from X-ray. Faham tak? Because heart ni dia turn. So that's why you akan nampak the mediastinum is small because the AO and PA looks like overlapping each other in TGA. Okay, so that's explained. That's why you get the changes in ECG. Faham tak? Because the ECG reflects the movement of impulse from the SA nodes to LA nodes, and then to the bundle of His and Purkinje fibers, and then through the ventricles, then up to and finally to the ventricle lah, iaitu the flow of the impulse. But because of the anatomical changes, you will see the disruption of the flow. So the SA node will change position. Okay, that's why you will see the changes in the P wave. This is quite complicated. I need to draw actually. Okay, okay. Back to basic. Okay, what is sinus rhythm? Okay, anyone know what is sinus rhythm? Okay. Okay, good. Okay, so the definition is means sinus rhythm is rhythm that is actually originated from the SA nodes kan. Okay, that's why we see, and because SA nodes is actually at the atrium, so that's why we see P is upward in all of the leads except for AVR kan. In AVR je yang dia kan downwards because it's originate from because of the position, then P will upright. Okay, faham tak? Because the flow is actually I think lukis lah. You have to imagine the axis kan, the axis. Okay, so when PA and OA is actually turn, and so do in LTGA, the RV and LV also switch. So you get all these changes because you've got changes in the flow of the impulse. That's explain the ECG changes lah. But that's why it's very detailed. I think I pun tak tahu the ECG changes of CCTGA. But they will definitely there. To number one. Number two is because LV is supposed to be very thick and very strong, and it conduct a lot of impulse. Okay, that's why LV impulse from LV, the QRS is very wide and very tall. Okay, faham tak? QRS if it's originated from the LV, it is very wide and very tall. That's why if you see like left ventricle hypertrophy, you will see tall R kan? Because it reflects the amount of impulse from the LV. So just imagine your LV is a strong muscle, but after a while it just pumps through to the circulation, to the pulmonary circulation. So after a while it will become weakened. Faham tak? Kalau you ni kuat and you ada banyak muscle, tapi you tak angkat berat, lama-lama what happen to your muscle? Dia akan weaken kan, dia akan become less hypertrophic, dia akan more hypotrophic. So later on dia akan jadi weak. Okay, and you akan develop heart failure. Okay, RV on the other hand is very weak muscle, tapi dia kena push against systemic circulation yang very high resistance. So tapi dia tak boleh hypertrophy banyak because dia punya amount of muscle is not much. So lama-lama dia akan fail. So the first fail that occur in TGA if not corrected, Okay, most TGA they can live as long as they've got a shunt. Okay, especially at atrial level atau PDA. If they got shunt dekat atrial level, they can survive. But usually they will die of failure lah, because the first thing happen is right ventricle will become fail and cannot push any more blood to the systemic circulation, and later on left ventricle also will become fail because become overload. Okay, faham kan?
Faham doktor. Meaning doktor kalau congenital corrected, in Nelson mentioned that most of it is associated with other defect, tapi kalau dia isolated sahaja pun kita kena correct juga.
Okay, in general kan TGA, if we got simple TGA, which means TGA without any septal defect, they cannot live. Okay. They will die. Okay, you need immediate intervention, which is the BAS lah. You need BAS, BAS lah, balloon atrioseptotomy. So you need to create an NASD lah, which you need to destroy the flap of the PFO. Because baby with TGA, if they got simple TGA without any shunting, okay, once the PFO close, they will die. So you need to do angio, and you need to destroy the flap of the PFO to create an ASD before you actually go to the definite surgery lah, which is the arterial switch or Rastelli lah. Okay, faham kan?
Faham doktor. Thank
Okay,
you.
TGA is almost always associated with either PDA or ASD or VSD. But those with VSD, you still need PFO. You still need to do BAS. Tapi those with ASD, they will asymptomatic. There will be sinus lah. After a while, there will be sinus. But later on, if you did not correct the switch, if you not switch the blood vessels, they will become fail lah. They will fail, die of failure. You faham? Okay. Okay. Ada any other questions tak? So, okay, this is very important slide. Okay, Zafran ada soalan?
Oh, I would like to ask the question because about I've read there is macam decreased pulmonary blood flow and increased pulmonary blood flow. Under the decreased pulmonary blood flow, it is a mixing lesion with with obstruction. Is there any specific disease or specific defect?
Okay, okay. In general, okay, in general, you need to understand the pathology, the pathophysiology of cyanosis kan. There's a few ways you can become sinus. Okay, first is when you've got obstruction at the right outflow. Okay, means obstruction at the level of pulmonary artery and below. Okay, this is what we call the PS, critical PS, TA, kan? PA, pulmonary atresia, or critical PS, critical pulmonary stenosis, or you've got tricuspid atresia or critical tricuspid stenosis, or TOF, which means all these they are sinus because not much blood goes to the lung. So if there's this restricted blood into the lung, that's what we call obstruction. Obstruction at the right ventricular outflow. So this is what we call obstruction at the right ventricular outflow, leads to reduced blood supply to the lung, therefore reduce blood return to the left ventricle. Oxygenated blood return to the ventricle is reduced, therefore reduce systemic circulation as well. Faham tak? So they will get less oxygen lah. Okay, that's one pathophysiology of cyanosis. Second is mixing. Okay, very typical mixing is truncus atriosus. Okay, when we got in truncus atriosus, both LV and RV outflow goes into a common blood vessel. Kan, later on distally baru dia spread into pulmonary artery and aorta. Tapi proximally they originated from a single blood vessel. So there's a mixing. So truncus atriosus is a pure mixing. Okay, and it's not restricted. So they can develop failure lah, because now double volume goes to the lung and also can goes to systemic. Okay, faham? Okay, uh, so you have to understand some especially complex scientific heart, they've got mixture of both pathology. Okay, for example, like TAPVD. Okay, TAPVD is the most complex lah. Actually, with a single defect, TAPVD is one of the most complex. Because what happened is the blood return, okay, doesn't goes to the left side, it goes back to the right side. Okay, that's the problem of TAPVD is the blood from pulmonary is actually goes back to the right side. It doesn't goes to the left side, it goes back to the right side. So oxygenated blood, deoxygenated blood will be oxygenated and then goes back to the right side to be oxygenated again without go to the circulation, without going to the left side. So so this is another pathology lah. So another one pathology is mixing. The other one is restricted blood to the pulmonary circulation, and the other one is two separate circulation system. This is the TGA and also the TAPVD. Same pathophysiology, which means the right side supplying the right side, the left side supplying the left side, or vice versa. Okay, faham kan? TAPVD ni. So your question tadi apa? Restricted. So restricted means simple je. Restricted lung, macam you mentioned just now, you divided sciatic heart into two, reduce pulmonary blood flow and also increase pulmonary blood flow. The one that reduce pulmonary blood flow means there's a restricted blood to the lung, and those that increase pulmonary blood flow is when there's mixing, so double volume goes to the lung. So the difference, the important to recognize the difference is these two groups will present differently. Okay, those with increased pulmonary blood flow, they will present with failure. Those with reduced pulmonary blood flow, they won't become fail. So you cannot say, for example, if you got a patient who is sinus and failure symptoms, breathlessness, hepatomegaly, tachycardic, tachypneic, you cannot say this is TOF, then you are wrong. Okay, TOF should not be in your differential because this patient is in failure. For example, you did physical examination and you confirm patient memang in failure. Okay, ada hepatomegaly and then tachypneic, tachycardic, ada gallop rhythm. So this is fail. Patient is failure. And then on top of that, patient also sinus. So you cannot put TOF in your diagnosis because TOF, they cannot develop failure symptoms. Okay, except for some rare cases, which is quite atypical lah. But your level, you cannot say TOF. Okay, faham kan? So the sciatic heart with restricted blood supply to the pulmonary, you cannot say it. They won't develop failure. So TA, PA, they will not become fail, but they will become severely sinus and they die because of that. So TOF they develop tu lah, TED spell lah, hypersensitive spell. Okay, good. Okay kan? Macam banyak pula ni. Any other
Okay, thank you, Doctor.
Okay, so let's go to this. I don't think we can finish this, tapi try lah. Sampai you guys penat or I penat. Okay, next. Because I thought you just want to list down the scientific and ascientific, tapi because you want to go into detail, then we go into detail now. Next is chapter dependent.
Assalamualaikum warahmatullahi wabarakatuh and good morning everyone. I am Akila Yunus and today I'll be presenting on acyanotic congenital heart disease. So acyanotic congenital heart disease can be divided into three classification. The first one is left to right shunt, second is obstructive lesion, and third is regurgitant lesion. So first we will go to the left to right shunt, and first we will see VSD, ventricular septal defect. So VSD is the most common congenital heart disease. It is more common in girls, and the prevalence is about 25 to 30%. So by the name itself, ventricular septal defect, we know that there is defect in the ventricular septum due to the malformation during the early gestation of development of the ventricular septum. So, as you can see in this picture, when there is defect in the ventricular septum, because the left ventricle has higher pressure than the right ventricle, then there will be left to right shunt. So the oxygenated blood from the left ventricle will enter to the right ventricle and cause mixing. However, there is no apparent cyanosis in patient because the oxygenated blood in the left ventricle is still preserved. And for VST, we can divide it into membranous type and also muscular type. The more common is membranous type, in which membranous type can be further divided into infracrystal and also supracrystal. And among these two, infracrystal is more common than supracrystal. However, supracrystal, the location of the defect is actually close to the aortic valve. So therefore, in supracrystal VST, it is more commonly associated with aortic insufficiency. So if you get patient who has supracrystal VST, in the echo, we also have to look at the aortic valve function because it is commonly associated with aortic insufficiency. And then the second type of VST is the muscular type. The muscular type is relatively less common than the membranous type. However, it is, as compared to membranous type, muscular type has higher chance of spontaneous closure. And then the muscular type can be further divided whether it is single or multiple, which is also called Swiss cheese muscular VST. And as for the presentation, it actually depends on the size of VST. We can say the VST is small if it is about the size of aortic valve, which is less than 3 millimeter to 5 millimeter. And we can say it is a large, moderate to large VST if the lesion size is as big as the aortic valve or even bigger than aortic valve. So it's about more than 5 millimeter or more than 1 centimeter. And as for the presentation, they will usually come with failure symptoms because of the left to right shunt, which cause increase in the pulmonary blood flow. So with increase in the pulmonary blood flow, so there will be increased return of blood to the left atrium and also to the left ventricle, which then will cause changes in the left atrium and also left ventricle first, which is left atrial dilatation more than hypertrophy because it is volume overload rather than pressure overload. And then with chronic increase in pulmonary circulation or increase in pulmonary blood flow chronically, they can develop pulmonary hypertension, which is then can cause Asperger syndrome, which cause the right to left shunt. And then at that point of time, only will patient has cyanosis. Okay, the next one is ASD, atrial septal defect. Also, through the name itself, you can know that the defect occurs in the atrial septum. And ASD is less common than VSD because it occurs in about 6 to 8% of population of children. And it is also more common in girls. And in ASD, there are several types of ASD. There are actually 4 types of ASD. The most common is ostium secundum, or we can also call a secundum ASD, in which the defect is in the deficiency of the foramen ovale. So in ostium secundum or secundum ASD, at the area of foramen ovale, it is deficient. So when there's deficient, there will be left to right shunting, left atrium to the right atrium punya shunting. Okay. And then the second type is called ostium primum or primum ASD. And in this ostium primum ASD, it is associated with AVSD, or we can also call as endocardial cushion defect. So later I'll talk about AVSD, but as general principle, AVSD can be divided into partial or complete AVSD. In partial AVSD, there is partial AVSD ni kiranya it is the same as primum ASD or ostium primum tadi, because in ostium primum ASD, the defect is in the endocardial cushion and also atrial septum, and also associated with aortic valve insufficiency. However, in complete AVSD, there will also be addition of ventricular septum defect in addition to the atrial septum defect and also AV valve insufficiency. And the third one is sinus venosus defect, in which the defect will be at the junction of entrance between superior vena cava or inferior vena cava into the right atrium. The defect will be there at the junction. And fourth is the coronary sinus defect, in which the defect occurs at the coronary sinus, and this is the most rare type of ASD. Also, the presentation will be much similar with VSD because both will have left to right shunt. However, because the defect occurs in ASD, it is not as severe as that occurs in VSD. So, patient will usually be asymptomatic. However, in large defect, patient can be symptomatic and also may present with failure symptoms. Okay. And among the physical signs which distinguish ASD from others are that in ASD there will be fixed splitting of S2 because of the defect in ASD. It causes equalization of pressure between the left atrium and also right atrium, so it causes fixed splitting, which means the splitting of S2, which consists of aortic component A2 and also pulmonary component P2, it will be consistently widely split during both inspiration and also expiration because of the equalization of pressure in the left atrium and also the right atrium. Okay. And next is PDA. In patent ductus arteriosus, as have been mentioned by our colleague earlier, the ductus arteriosus functionally should be closed within 13 to 15 hours or about 14 hours. And in some, it may persist up to 14 days. However, if it persists longer than that, patient may have patent ductus arteriosus. So, in patent ductus arteriosus, in the fetal circulation, the flow of blood in ductus arteriosus is from right to left. However, when the baby is born, as after after weeks or after 1 week or after weeks in which pulmonary vascular resistance start to decrease, supposedly the ductus arteriosus is already closed, right? But in patent ductus arteriosus, when this pulmonary vascular resistance close, however, there's still patency of the ductus arteriosus, so blood will flow from the aorta in its left to right side into the pulmonary artery circulation and also cause increase in the pulmonary flow. And also, it has similar presentation with VSD, ASD, and also AVSD, in which patient may come with failure symptom. Okay. With VSD, the type of murmur will be ejection systolic murmur at the left lower sternal edge. With ASD, the murmur will be pansystolic murmur at the left upper sternal edge. And with PDA, there will be continuous machinery murmur best heard at the left infraclavicular area. And in all this left to right shunting, on the chest X-ray, you can it actually depends on the ECG finding and also chest X-ray finding. It depends on the size of the lesion itself. With small lesion, patient may have relatively normal chest X-ray and ECG. However, in larger lesion, they may have signs of left ventricular hypertrophy, or with consistently high pulmonary blood flow, they may develop biventricular hypertrophy, also affecting the right ventricles itself. And also on the chest X-ray, you can see cardiomegaly with large defect, and also you can see a plethoric lung fill due to the increased pulmonary blood flow. Okay, so that's about the left to right sign. Now we move on to the obstructive lesion. So, why is the name obstructive lesion? Because there is obstruction in the blood flow. So first, we will talk about coarctation of aorta. We first talk about coarctation of aorta, in which there is narrowing of the aortic arch. It can be from the aortic arch down until the bifurcation up to the iliac artery. So therefore, we need a CT thorax to identify where the narrowing ends are. Preoperative, in order for us to determine the intervention later. And this coarctation of aorta almost always occur juxtaductal. What does it mean by juxtaductal? It means that near the ductus arteriosus. So it can occur either preductal or postductal. So in preductal coarctation of aorta, or we can also call it as infantile coarctation of aorta, because it usually presents early in life in infancy. And in this preductal coarctation of aorta, in preductal, it means that the lesion occurs before the ductus arteriosus. So in this situation, patient usually present early, and also it may be associated with arch hypoplasia. But it may be associated with arch hypoplasia, but not necessarily associated with arch hypoplasia. And in preductal coarctation of aorta, as soon as the ductus arteriosus normally close, so macam ni nak cakap,
Okay, right after the baby is born, the pulmonary vascular resistance will start to reduce. And also, after some time, the ductus arteriosus will close. Initially, before the ductus arteriosus close, patient can still have circulation into the systemic circulation via the patency of ductus arteriosus. So, patient can still have blood supply towards the lower limb, you can see, from the ductus arteriosus itself. But however, as soon as the ductus arteriosus start to obliterate normally, so patient will present with signs of obstructive shock. So there will be hypotension and signs of shock lah, basically. So, in this case, pre-ductal coarctation of aorta, we have to give immediate prostaglandin in order to maintain the patency of ductus arteriosus so that the systemic circulation to the lower limb will be preserved. And the second one is post-ductal coarctation of aorta. So in post-ductal coarctation of aorta, the constriction or the narrowing occurs after the ductus arteriosus. And in this type of patient, we also call it as adult type of coarctation of aorta. They may remain undiagnosed until they are in adult age, and the presentation at adult would be they can have hypertension of the upper limb with lower blood pressure over the lower limb, and also they may also have radiofemoral delay due to reduced blood flow to the lower limb relatively. And in this coarctation of aorta, the type of murmur we will hear is ejection systolic murmur, which usually radiates to the interscapular or infrascapular area. In the chest X-ray, usually we will see normal chest X-ray, but sometimes there may also be rib notching due to the development of multiple collaterals of the intercostal artery. And also for the murmur in coarctation of aorta, as I mentioned earlier, it is ejection systolic murmur because during systole there is obstruction towards the outflow tract over the aortic arch. However, if collateral vessels start to develop over the intercostal artery, we can also hear continuous murmur throughout our chest, throughout the patient's chest, because of the presence of these collateral vessels of intercostal artery. And then next, obstructive lesion will be pulmonary stenosis and also aortic stenosis. Both will occur due to the failure of development of the leaflets of this valve. Usually in pulmonary valve and also aortic valve, they will have 3 leaflets, but with failure of development of these 3 leaflets of the valve, they will have pulmonary stenosis and also aortic stenosis. So patient will present with usually failure symptoms. They may have exertional dyspnea and also easy fatigability. With aortic stenosis, they can also present with syncope. And the type of murmur that we will hear in pulmonary stenosis and also aortic stenosis is ejection systolic murmur. And sometimes you'll also hear systolic ejection clip due to the stenos valve, which is hard to open. We will hear the systolic ejection clip at that point of time. And next is rigidity condition. So
condition, I think we can skip because it's not in
not
pediatric
common.
unless it's acquired.
Mm,
Okay, in rheumatic heart. If not, you won't see this.
okay.
Okay, actually the most common heart defect is bicuspid
Because aortic valve.
aortic valve. That's the most common. Second is VSD. But aortic valve usually
Seen in
asymptomatic.
adult.
We won't diagnose them. Okay, that's very good, very detailed and thorough. However, actually pulmonary stenosis, they rarely develop dyspnea. They won't get dyspnea in pulmonary stenosis. In aortic stenosis, they do. Okay. Remember, any lesion, obstructive lesion at the right side before the pulmonary is protective of the lung. I mean, they will protect the lung, so you won't get dyspnea. Okay, what when we say failure symptoms, what do you mean by fail?
Relatively reduced cardiac output.
Okay, so relatively reduced
Reduced cardiac output in
okay.
compared to the metabolic demands.
Okay, that's what we call it shock. That's I mean that's when you say it's shock lah. Tapi when someone is in failure, uncontrolled failure, what they presented with dyspnea kan, very typical macam adult lah.
Edema macam mana?
Autopnia, dyspnea. Edema is actually right side. Okay, edema is right side. This is we're talking when we say heart failure, it's actually the left side. Okay, congestive heart failure baru both sides. Tapi kalau heart failure, even in pediatric heart failure, means left ventricular failure. Okay? And the symptoms is all the cardinal symptoms is actually the dyspnea lah, dyspnea. Tachypneic dyspnea, even in pediatric as well. So the reason is because there's a lot of blood in pulmonary circulation that cause them to drown. So heart failure ni the problem is because they are drowning. The lung is drowning because of the blood. There's a lot of blood due to the left ventricle fail to pump out blood efficiently to allow venous return from the pulmonary vein lah. Faham kan? So there's a congested of blood. So any lesion, obstructive lesion on the left side, including coarctation of the aorta, aortic stenosis, can actually leads to can actually cause failure symptoms now. Okay. So do the VSD, PDA, and also AVSD. Because in this lesion, there's increase in blood flow to the lung. Kan, not VSD kan, left side pergi right side, shunt is left to right. So now there's double volume through the PA in VSD. So do in PDA. Okay. So they've got failure symptoms. In aortic stenosis also they got failure symptoms because now reduce blood flow from lung to heart. So do coarctation of the aorta, so they can get failure symptoms. But in pulmonary stenosis, they won't get failure symptoms. And ASD also they won't get failure symptoms because in the atrium the pressure is low, so they just got the problem with volume. So it's not as bad as in PDA and VSD, because PDA and VSD we are talking about pressure gradient. So there's a lot of blood with high pressure, and I mean push towards the heart, towards the lung. But in ASD, there's a lot of blood but low pressure. So it's not actually affecting the lung much lah. Okay. So in ASD we call it relative pulmonary stenosis. That's why in ASD the murmur is similar to pulmonary stenosis. Actually, it's very difficult to differentiate pulmonary stenosis and also ASD. The site of the murmur is similar. Is exactly the same, except in ASD we've got the fixed splitting. Okay, remember So whenever you heard a murmur that you think is ASD, then your main differential diagnosis is pulmonary stenosis. Unless you can hear the fixed splitting, then definitely this is ASD lah. But it's very difficult to listen to hear the fixed splitting, especially when the child is tachycardic. Okay. So because ASD is similar, the pathophysiology is similar to pulmonary stenosis. It's just a relative pulmonary stenosis due to double volume blood go through the PA. Okay, ada any more question ke?
Sorry, Doctor, I would like to ask, for example, in the pulmonary stenosis, like you mentioned earlier, there will be relatively reduced blood flow towards the pulmonary circulation. So less blood will be oxygenated. So wouldn't the deoxygenated blood contribute to the shortness of breath or dyspnea in the patient?
Because dyspnea is only occur when there's a lot of blood in the lung. You won't get dyspnea because those with anemia kan. Anemia they don't get tachypneic. They don't become tachypneic unless it's very 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 severe anemia that cause the heart to fail. Kan kalau you ada very severe anemia that's not treated, finally your heart, because your heart when you're anemic, your heart will become tachycardic kan, to push more blood to the lung. Tapi because if you did not treat, then finally your heart will become tired and it's fail. That's when you get failure symptoms in anemia. Because of the blood currently cannot push out the blood the heart cannot push out the blood from the left ventricle, so congested the lung. But otherwise, if not, you won't get tachypnea. Because tachypnea is actually because of the pulmonary congestion. So in X-ray, simple je. For example, if you got a heart disease, okay, you've got someone yang you rasa this is a heart problem. So you have to determine this is sinus or not sinus. Okay. Then look at the ECG, look at the X-ray. Okay. If the X-ray is plethoric, then you know the defect is actually on the left side. Most of the time, the defect is on the left side, or the pathophysiology is increased blood flow to the lung. Okay. So that's how you narrow down your diagnosis lah. So patient is sinus, okay, for example, patient is sinus, and on top of that, lung dia plethoric. Okay, murmur you tak tahu murmur apa. So what condition sinus and plethoric lung? Oh, ni mesti truncus atriosus. Ataupun the other possible is TAPVD. TAPVD pun TAPVD lah. Ataupun usually TAPVD you tak jumpa lah because they die early. Most of them tak sempat KJN untuk ni. Okay, macam tu lah. So you punya differential tak banyak. TGA maybe. Kalau TGA underwent bust, then you may see them alive lah. Okay. Tapi kalau contoh you nampak X-ray patient sinus and then lung dia oligamic, tak plethoric, then you can bet on TOF lah. TOF is the most common. Ni kan, kalau you cakap TOF, you tak payah examine one patient ni, you tengok je nampak patient sinus, you tengok X-ray, oligamic, TOF lah. You can just say TOF, no one will blame you because TOF is very common and is top of the list. Because not many cyanotic heart with that presentation lah. The other option is the ni is apa PAPV. Epstein, you can get Epstein. Epstein also you get very oligamic lung. Tapi Epstein you tengok X-ray you boleh tahu lah Epstein. Epstein is very easy to diagnose and you will never see Epstein because they either died, okay, because Epstein you cannot fix. So they either died at day 1, 2, 3 of life, or you never know they got Epstein until you do X-ray. A lot of Epstein dia extreme tau. Either they mati waktu they died at very young age ataupun umur 50 tahun buat X-ray, Epstein anomaly. Okay, they won't be detected. Those yang mild Epstein won't be detected, usually accidentally detected by X-ray. But those yang Epstein, very bad Epstein, dia akan mati very early now. Oh, you did mention about Epstein anomaly kan? So Epstein anomaly just arterialization of right ventricle, which means the setting of the tricuspid valve become lowered. So maksud tricuspid valve ni dia rendah. So dia punya right ventricle tu become smaller, become very small, and right atrium become very big. So they become sinus because reduced blood circulation to the pulmonary. But the one Epstein is rare, taklah rare sangat, it's rare because a lot of them undiagnosed and a lot of them die very early, so you won't see them. Occasionally you see them lah, tapi rare lah. Okay, next. Ada soalan? Because in general, acyanotic is more common than cyanotic, and cyanotic you will usually kalau cyanotic you tahu TOF. TOF you have to know in out lah because it's very common. Definitely will come out in the exam lah. Kalau you get a cyanotic heart, you just bet this is TOF. You without examination, without anything, just cakap TOF. Then chances untuk you betul is about 80%. Okay, next. Kat standard. Yang ni actually dah mention tadi. Tapi okay lah, just briefly describe.
Okay. So Assalamualaikum warahmatullahi wabarakatuh. So my name is Muhammad Aklan. Inshallah I will be presenting a bit about the doctor dependent edition. So my main sources will be from Nelson Essential and also Nelson textbook of pediatric. So if you go into the textbook, there's no specific topic that combines and correlates all this into a one singular topic, but rather it is dispersed into respective topics. So this one is the what I've compiled from each pathology. So ductal-dependent lesion, as the name suggests, meaning that the lesion is actually dependent on the ductal patency in order to maintain fetal viability. So in other words, either you need that shunt to give pulmonary blood flow or to give the systemic blood flow. Jasly, something is obstructing the. Alright. Okay. So largely it can be divided into ductus dependent systemic circulation and also ductus dependent pulmonary circulation. In other words, the systemic circulations would rely on the shunting to occur in order to provide the systemic perfusion, whereas the ductus dependent pulmonary circulations relies on the patency of the ductus arteriosus in order to supply for the pulmonary circulation. So these are the list of pathology. Most of them are already covered by Zafira and Akila. However, I will only touch a bit about those that it has not been covered yet. So let's talk about interrupted aortic arch. So interrupted aortic arch, if you look into, okay, look at the picture below. So we have the, macam mana? Just, can you, tak apalah, macam mana nak point? Yeah, tak apalah. So based on Nelson, interrupted aortic arch is actually the severest form of coarctation of the aorta. So as we learned before that, one of the mechanism that is postulated is actually because of the contractile tissue that migrates abnormally into the from outside from the ductus arteriosus. So this contractile tissue will then cause the coarctations to occur. So interrupted aortic arch is actually the total interruptions of the aortic arch. So it has three types: type A, type B, and also type C. So if you look at the diagram below, the one that Jasly is pointing the pointer to, so we can see the PDA, and then we can see the three trunk at above. We have the brachiocephalic, we have the left common carotid, and also left subclavian artery. So type A, which is the commonest type, there will be interruption of arch at the level distal to the origin of the left subclavian artery to the point before the ductus arteriosus. Okay, so that's the commonest type. Okay, sebelah sikit Jazli, sebelah kanan sikit. Antara left subclavian artery punya distal to its origin to the just before the PDA punya origin. Okay, so that's the type A. Type B kat tengah-tengah. It is actually originates in between the subclavian artery left side and also left common carotid, extend to the point. Macam mana? I think I need to use the point. Yes, that one. Just tunjuk that point. Okay. That one is type B, and type C will be in between the originates in between the left common carotid, brachiocephalic, and also to the point proximal to the PDA punya side. So actually, it is called ductal dependent because there's a total obliteration of the aortic arch. Hence, the systemic circulation will totally depends on PDA. Okay, and then we move on to the next one. Let's go into the ductus dependent pulmonary circulation. So TOF already covered, pulmonary atresia, pulmonary stenosis already covered. Let's talk about single ventricle. So single ventricle is actually one of the anomaly where there is a single ventricle only, as the name suggests. So both the right and left atrium will drain into a singular ventricle. So it can either drain via a common common valve, atrioventricular valve, or it can be draining by separate the tricuspid and also the mitral valve into the single ventricle. So these singular ventricles will then give both systemic and also pulmonary circulation. However, in single ventricle, it is very common to be associated with either pulmonary stenosis or pulmonary atresia. Hence, the why it is ductal dependent is because it must rely on the patency of the ductus arteriosus in order to supply the pulmonary circulations, because it is very common to have pulmonary atresia and also pulmonary stenosis in such lesion. That's why it is called ductal dependent. Okay, now we look into the Epstein anomaly. So Epstein anomaly, as doctor mentioned just now, is actually it is the abnormality of the tricuspid valve. So tricuspid valve have three leaflets. So we have the anterior, posterior, and also the septal leaflet. So in this Epstein anomaly, there will be apical displacement. In other words, there will be downward displacements of the septal and also the posterior valvular leaflet. So okay, so imagine that, look at the right ventricle, just pointing just now. Try to divide it into two. So why is mentioned doctor mentioned just now that it will be arterialization of the right ventricle because the downward displacements of the posterior and also the septal valvular leaflets will create as if the right ventricle into two segments. The above the superior one will be the one that has undergo the arterialization, and the inferior one will be the remaining right ventricle. So in these such cases, there will be a lack of pulmonary blood flow because of three reasons. First and foremost, there will be weak right ventricular function. There will be severe tricuspid regurgitation because we know that the abnormalities is actually is at the leaflets of the tricuspid valve. And the third one will be the one that is not displaced, the anterior leaflet is actually it will form a obstruction into the right ventricular outflow. So all in all, these three pathology, the obstruction by the anterior leaflet, the reduced in right ventricular function, and also because of the tricuspid regurgitation, all in all, these three will lead to decrease in pulmonary flow. So that is why it is ductal dependent, because it must rely on the ductus arteriosus in order to maintain the pulmonary circulation. Now let's look into the. Okay, I think that's about it. Yeah, the rest of the pathology already covered by other presenter. So management wise, this one is by Prof. Ismail mentioned that if you have a baby with cyanosis or with shock, but you don't have the modality of echo, just start away with prostaglandin E1 infusion 0.01 to 0.2 microgram per kg per minute. Start away in the presumption that these cases are ductal dependent lesion, because it must rely on this patency in order to maintain viability. I think that's about it with regards to my topic. I open the floor to any questions.
That's very good. That's very good. Any question?
I have questions.
Yes.
I have question about the data dependent. Is it
Yes.
the data dependent only depends on the pattern data choices or anywhere like ASD or VSD?
Okay. Good question. To be honest, I am not sure about the answer. I open the question to doctor.
Okay. Ductal dependence means depending on the ductus, ductus heterosis, which means this child, this baby, without corrective surgery, they have to underwent a palliative intervention to keep the patency of the PDA. Okay, so any of this lesion, okay, that ductal dependence, if you don't, if you didn't do anything to create a ductus, a shunt, left to right shunt at the left side, bukan right side tau, right side shunt ni macam PFO, ASD, tapi left right shunt macam PDA, then they will not survive lah. So ductal dependence is dependent on the PDA. So in order for them to live, you have to give them PGE until definite plan is there, corrective surgery is planned, or you can create another shunt, for example like BT shunt lah, bilotoxic shunt. So the aim is this lesion, in general, this lesion, they become ductal dependent because lack of blood supply to the pulmonary. So they need something to bring the blood from the right side to the pulmonary. That's the principle. So anything can do. Anything can that can bring blood from the right side to pulmonary is what they need. So which is PDA je lah yang ada. Because VSD just connection between left and right ventricle. VSD they did not guarantee the blood supply to the pulmonary kan. Especially kalau the lesion is actually at the pulmonary valve and above. Then VSD has no role. No role. Faham tak? Kalau contoh you ada pulmonary atresia kan, pulmonary valve atresia, then you buatlah VSD pun, the blood won't get to the lung. Okay, faham tak? What you need is PDA to bypass the pulmonary artery circulation. Okay, and the other option is as I mentioned is bilotoxic shunt lah. Okay, BT shunt. BT shunt is simple. BT shunt, you've got a lot of BT shunt. You've got modified semua. Tapi BT shunt, the principle is you divert blood, okay, from the from the right side, which is from the vein or from the superior vena cava or its branches to the pulmonary artery. Faham kan? Okay, sentence lah. Okay, good. Ada
Okay,
question?
thank you, Doctor.
Okay. Next presentation. You guys boleh continue ke? Ke penat lah?
Okay,
Boleh, Doktor.
Tukar tak? Tak tukar. Oh ya. Nampak ke? Tukar? Oh ya. Jangan disconnect. Jangan. Betul.
Ni siapa ni nama?
Mimi boleh buka Mimi?
Boleh, kalau tak boleh
Screen share je kan?
Apa?
Saya screen share ke?
Boleh ke?
Tapi gambar je lah kejap
Lambat sikit. Okay, dah boleh ya? Okay.
Assalamualaikum warahmatullahi wabarakatuh. My name is Shamimi. So I'll be presenting about the scars in congenital disease. So the three main scars which is usually done in patient with congenital disease is median sternotomy scar, left thoracotomy scar, and also the right thoracotomy scar. So mainly for the cardiac surgery in congenital disease, many of the procedure require the median sternotomy incision. Why median sternotomy is preferred? Because median sternotomy offers a good exposure of the heart, pericardium, blood vessel, thymus, anterior mediastinal structure, lower trachea and carina, also the bilateral pulmonary procedure. So the median sternotomy scar is required in majority case of congenital disease. So what is the advantage of the median sternotomy incision? It is quick to perform and also less pain. But the disadvantage of the median sternotomy is that it has bad cosmetic because of the scar we can see at the middle of the chest, and also there is risk of the sternal malunion in the median sternotomy scar. Because of the malunion, the patient is exposed to post-operative infection. For the median sternotomy scar, the indication is that in what case that we can do the median sternotomy incision. The first one is tetralogy of Fallot. In tetralogy of Fallot, we can do open surgery, which is done between 6 months to 2 years old. And there is two types of surgery in tetralogy of Fallot, which is palliative surgery or corrective surgery. For palliative surgery, we do before the corrective surgery, and it is indicated in patient who has a complex form of tetralogy of Fallot. So in the palliative surgery, we do the modified Belleloctosis shunt, BT shunt, in which we make a shunt between the subclavian artery and also pulmonary artery in order to bypass the heart. So in this surgery, we can do either sternotomy, which is the median sternotomy incision, or we can also do the left thoracotomy. But in the palliative surgery, we prefer to do left thoracotomy because we need to preserve the sternum for the next corrective surgery later.
So in corrective surgery, in tetralogy of Elliot, we do the median sternotomy, and in tetralogy of Elliot, what we do after we do the median sternotomy incision, we close the VSD, and also we open the pulmonary stenosis so that more blood can flow to the lung. Okay, and then the next procedure which require the median sternotomy incision is transposition of great artery. For the transposition of great artery, we do possibly then shortly after birth or within 2 weeks of life. And in transposition of great artery, we do we switch aorta and pulmonary artery. So we switch aorta and coronary artery to the left ventricle and the pulmonary artery to the right ventricle. The third one is aortic valve surgery. So in aortic valve surgery, the example is aortic stenosis, and we do open surgery in aortic stenosis where we do the midline incision in case the balloon valvuloplasty is failed. So we can do the aortic valve replacement. And the next one is Fontan procedure. We also do median sternotomy in Fontan procedure. So in what case we do Fontan procedure? It is we do in hypoplastic left heart syndrome and also tricuspid atresia. So in Fontan procedure, we redirect blood from the lower limb to the pulmonary artery and then to the lung. So in hypoplastic left heart syndrome, we can use the right ventricle to pump the blood to other body parts, and then for the blood to be pumped to the lung, we use the Fontan procedure where we create inferior vena cava to the pulmonary artery via the conduit. Okay. And the next one is central shunt. We also do median sternotomy incision. It is done whenever the bladder and intersection is failed. And the last one is pulmonary artery bending. It is used in the past in case of ventricular septal defect and transposition of great artery. The pulmonary artery bending we do in order to reduce the pulmonary blood flow so that there is no pulmonary hypertension, because in VST and TGA there is pulmonary hypertension. But we no longer use the pulmonary artery bending.
Okay, tak betul. Itu je.
Next is left thoracotomy scar. For the left thoracotomy scar, we can do either anterolateral, posterolateral, and also axillary. The first procedure that we can do in left thoracotomy incision is that the repair of coarctation of aorta. Why repair of coarctation of aorta? We can do the left thoracotomy because, as our previous presenter said, that the coarctation of aorta usually occur at the ductus arteriosus, right, near the ductus arteriosus, so at the juxta ductal region. So the ductus arteriosus actually located at the left side of our thorax, of our thoracic. So it is suitable for us to do the left thoracotomy. For the repair of coarctation of aorta, we usually do at the age of 3 to 5 years old, and we do if there is significant hypertension or congestive heart failure. And the type of surgery that we can do in coarctation of aorta is one of the example is left subclavian flap aortoplasty. In this procedure, we take the subclavian artery and do flap at the aorta at the coarctation region, at the constricted region, so that the size of aorta will be larger for more blood flow can occur. Okay, and then the second one is ligation of patent ductus arteriosus. Why we do ligation of patent ductus arteriosus? Why we do at the lateral left thoracotomy? Because like I mentioned before, ductus arteriosus is located at the left side of the thorax. So we do the ligation of patent ductus arteriosus during infancy, and indicated if there is failure of indomethacin treatment to close the ductus arteriosus, or if there is sign and symptom of congestive heart failure. And the third one is bladder intoxication. For the bladder intoxication, as I mentioned before, we can do either median stenotomy in case of the tetralogy of Fayette, or we can also do the left thoracotomy. So bladder intoxication we do in case of tetralogy of Fayette or tricuspid atresia. Okay. For the right thoracotomy, the indication is that we can do the right thoracotomy in case of pulmonary artery bending, which also can be done in left thoracotomy or right bladder dissection. For the right bladder dissection, bladder dissection can be done left or right. It is based on where the aortic arch of a person is located. Because in a normal person, the aortic arch usually located at the left. But in some patient, which is a normal variance, the aortic arch can be at the left side. So when the aortic arch is at the left side, we have to do the bladder intersection at the right side. Okay. And then for the scar at the left upper chest, usually the procedure that require left upper chest incision which produce the scar is pacemaker, defibrillator, and also resynchronization device. And there is also chest drain scar located at the lower part of the sternum, which is required for pleural effusion, empyema, and also pneumothorax. Besides, there is also minimally invasive surgery, minimally invasive scar at the right upper side of the thorax, which is indicated in case of repair of septal defects, tricuspid valve surgery, aortic valve surgery, or mitral valve surgery. Okay, that's all.
Okay, that's quite thorough. Except for a few yang I think what you've mentioned here is quite updated lah. Which updated is not the things that we do in Malaysia because we are still outdated. So things like, for example, you've mentioned PA bending was no longer done. So essentially PA bending is one of the most common procedure that we've done in Malaysia, like in Malaysia setting. Because as we mentioned, the VSD, for example, like things like VSD, we usually correct it AVSD and also AVSD we correct it very early. Nowadays, even TGA kan, TGA pun, TGA we correct it during neonatal period, for example. And then VSD we correct it within the first 1 year of life. So do AVSD. That's the idea. Okay, but in Malaysian situation, because that we are lacking of center to do it and expertise. Apparently cardiothoracic surgeon, pediatric cardiac surgeon is very interesting and very highly demanded career lah kalau you guys want to pursue.
Hello. Doktor start.
Dengar tak?
Baru dengar doktor.
Okay, sorry. Okay. So in general, dengar kan?
Dengar.
Okay, in general, there's two type of surgery, palliative and also corrective surgery. Okay, palliative surgery is a surgery that you did to give time before corrective surgery can be done. So these are like PA bending, BT shunt, Glenn, Fontan. These are all actually palliative surgery lah. Okay, corrective surgery like arterial switch, Rastelli, PDA closure, PDA ligation. These are all corrective surgery. So in PA bending, what we did is actually we restricted blood to the lung. As I mentioned, the the main problem with septal defect like VSD or also connection like shunt like PDA kan, the main problem is there's a lot of blood to the lung with high pressure that actually damaging the lung, and this cause all the symptoms of failure kan. So in order to control the symptoms of failure, to allow the child to grow, kan, to allow the child to grow better, and also palliate the symptoms, you do PA bending. So you do PA bending at very young age during neonatal period. You can also do PA bending in neonatal period. So do PA bending and give time for the child to grow without failure symptoms. Then after the child achieve like 10 kilo, then you can actually repair the shunt and also the septal defect. So PA bending, and then BT shunt also the same. So patient with doctor dependent, you can do PDA stenting. This is non-invasive. PDA stenting is less invasive. It's just through femoral artery lah, femoral artery or umbilical artery. So you can do PDA stenting or BT shunt. BT shunt is actually is palliative lah, to give time. Okay, Glenn and Fontan, like you mentioned, Fontan and Glenn is actually for those with single ventricle. Okay, anything with single ventricle, you do Fontan and Glenn. Okay, Glenn, actually I've wrongly mentioned just now about the petition. Petition is not connection between the vena cava and its branches to the pulmonary artery. Petition is actually from the aorta punya branches to the pulmonary artery. That's petition. So anything, it can be subclavian artery, it can be, usually we don't touch carotid artery lah. Most of the time it's subclavian artery, right or left. It can be right or left. Petition can be right subclavian or left subclavian artery. For central shunt, like you've mentioned, the central shunt ni, yang median sternotomy ni, central shunt is actually a petition, but it's actually from aorta directly to the pulmonary artery. It's very dangerous. We rarely do it, but sometimes we have to do it. Okay. So Glenn is the one I've mentioned earlier, which means Glenn is we divert the blood from the vena cava. It can actually from superior. Most of the time, it's superior vena cava to the to the pulmonary artery. So we bypass because there's only one ventricle. So the role of the right ventricle will be replaced by the shunt, Glenn shunt. That's what we call Glenn shunt. And then after Glenn is actually to prepare the heart, the lung, for high amount of blood. Then we do Fontan. But I think you don't need to know the detail of Fontan and Glenn lah. But in general, Glenn and Fontan is a treatment. It's a stages. It's a staged staged palliative surgery for single ventricle. Actually, one important thing that I forgot to mention is hypoplastic left heart syndrome, because you keep on mentioning a lot of time hypoplastic left heart syndrome. So hypoplastic left heart syndrome is a condition that is usually not compatible with life. Okay. When you say hypoplastic left heart syndrome, it has to be hypoplastic the whole left heart. So it's hypoplastic left ventricle, hypoplastic aorta, and also the hypoplastic aortic valve. That's when you call is hypoplastic left heart syndrome. But if it's hypoplastic left ventricle, then it's similar to like one ventricle ni lah. It's still, you can still palliate lah. You can do palliative surgery. But if a child diagnosed as hypoplastic left heart syndrome, we will withdraw and everything. We'll let the child die lah, because the child won't survive. Okay. So in general, there's no surgery for Epstein. There's no surgery for hypoplastic left heart syndrome. The rest, most of them got at least palliative surgery. Itu lah. So the scar untuk heart pun tak banyak sangat, especially in pediatric. Congenital heart, you rarely see implantable defib atau implantable pacemaker, unless in the case of complete heart block. Most of the time because of mother with SLE kan. Kalau mother with SLE with anti-low anti-la positive, they usually the baby can get complete heart block. So that's when you call pacemaker. Defib, usually prolonged QT syndrome, severe prolonged QT syndrome. In baby, they may have defib. So, or refractory SVT due to sick sinus syndrome, for example, then they may have defib implanted. I've seen one. I think I've seen two. One baby with defib. I think 2 or 3 baby with pacemaker lah inserted back in HUSM. Okay lah, tu cukup. Chest drain ni you have to identify. And the one very important scar that you've missed is actually the scar of angio lah. Angiogram ni scar. So when you examine a child with heart problem, with cardiac punya case lah, cardiac punya case, you have to examine the femoral side, okay, for a scar. Okay. Because sometimes patient ni, for example, dia kata, okay, this child had underwent a surgery for a congenital heart disease. Okay, there's nothing with the child. There's no scar on the chest. Okay, and the child is not breathless. The child is not sinus. Then chances are this is a PDA stenting, PDA. This is a VSD lah most of the time. Because VSD you can use coil kan. You can do minimally invasive using coil lah, using coil. Atau patient with coag, you can actually do angio lah untuk crack coag by using balloon, similar lah, balloon macam patient yang SCS kan. You boleh buat balloon balloon apa nama dia, yang you open the stenosis area using balloon lah, ataupun stent lah. Most of the time we use stenting of the coag is most of the time now we use angio. Angio is less invasive. And also VSD, even ASD, previously primum, secondum ASD, I mean most of the time we don't use device untuk secondum ASD. Why? Tadi siapa present ASD tadi? Azira
Saya, Doktor.
Okay. Kenapa ASD secondum kita tak guna device? What's dangerous about secondum ASD? ASD in general are not dangerous compared to the rest. ASD is less dangerous lah. Usually ASD we correct at the age of 7, 8 years, even 12, 13 years pun boleh correct lagi. Kalau VSD, after the age of 12 years, you tak correct, you will not correct. You cannot correct anymore because they will start to develop pulmonary hypertension and it started to become asthma lah soon. So VSD you correct very early, usually at the age of, in Malaysia setting 2, 3 years old. But actually recommended is 1 year old. Tapi Malaysia biasanya 2, 3 years old lah. Tapi ASD you can correct later. But most ASD you use you need to operate rather than using coil. Okay, because especially secondum ASD. Sebab apa? What important structure are there in ASD? Very near to ASD. It's the most important structure in the heart.
Bundle of his.
SA not.
SA not. SA not. Okay. So ASD, okay. A lot of the heart structural heart defect, they don't have problem with conduction except ASD. Okay, ASD, especially ASD secondum, they a lot of time they presented the child presented with syncopal attack ataupun presented with palpitation. Then bila buat echo noted ada ASD. So ASD, a lot of ASD they are asymptomatic. So dia tak ada, they don't develop failure. Tapi sometimes they can get arrhythmia. Okay, that's why most center they don't do device closure of ASD. Tapi in Kelantan, in USM and NSAD, is the largest center in the world that do device closure of ASD. Okay. So actually Malaysia is okay, quite good untuk in terms of cardiac punya surgery in pediatric. Malaysia is quite good. Tu dah. Rasa tu cukup. Anything else to ask? Rasa pun.
Doctor.
Ambil right.
It's okay. Just. Doctor. My question will be with regards to hypoplastic left heart syndrome. What about the role of Norwood procedure, Doctor?
Norwood Norwood is a staged procedure, but it's very high risk. It's very, and people nowadays, less people, I mean, we rarely do Norwood lah. Actually, I tak pernah dengar any of my baby do Norwood because it's very high risk. It's a stage procedure juga. And a lot of time baby with hypoplastic heart syndrome ni, it's very difficult to treat, manage, because they end up develop by the time lah dia ada activity, so you give they rely on PGE, but even though with PGE pun it won't correct their hypoxia much because they're hypoplastic, the left ventricle is not functioning. So most of them usually died very early lah. Because the main complication they get is they get shock, cardiogenic shock kan, cardiogenic shock, heart failure, and on top of that, they also got they develop kidney failure lah a lot. Because when you've got reduced output, when you've got problem with your left ventricular output kan, the main organ, the whole body organ down your waist is compromised lah, especially your liver and also your kidney. So a lot of time this baby memang end up ESR, CKD, liver failure, renal failure, and tak sempat lah buat no one. Itulah. Okay. Ada soalan?
I'm sorry, doctor. I would like to clarify. Usually kalau blood toxic shunt, is it like it must be from either right posterolateral or it can be from also median sternotomy because
Yes.
I saw there's like variation in the Google image.
Yes. Because it's as I mentioned BT shunt kan, BT shunt is a connection between the branch of aorta, okay, the branch of your aorta lah. Usually mainly we take the subclavian artery because that's the least useful and you've got collateral lah untuk replace it. You and then you shunt it to the pulmonary artery. So that's the principle. BT shunt is from left outflow to the right outflow. So dia connect aorta punya branch dengan pulmonary artery to the lung. So it can be any of the branches. Okay, so kalau you guna left subclavian artery, so you boleh buat left thoracotomy lah. Kalau you guna right subclavian artery, you gunalah right thoracotomy. You buatlah right thoracotomy. Tapi if this fail, especially contoh macam patient ni memang ada, most of time syndromic baby lah. Syndromic baby memang ada vascular dia pun not very good. Even pulmonary artery dia maybe memang susah lah. Kalau susah then worst come to worst, you kena buat median sternotomy and you connect the aorta using a shunt kan, conduit, you build a conduit. So BT shunt ni dulunya BT shunt is actually you just cut the subclavian artery and fix it to the pulmonary artery. Okay, so you use the subclavian artery straight to the pulmonary artery. But nowadays we use conduit, which mean you cut the subclavian artery, you tak cut pun subclavian artery tu. You just put a conduit macam pipe kan. In between, you buat lubang dekat subclavian artery tu, you fix it there, and then at the other end you fix to the pulmonary artery.
The conduit is from the pulmonary artery, doctor?
No, so the conduit is something yang usually made of apa material macam material lah, I pun tak ingat, tak sure material PVC macam tu lah.
It's not from the patient itself lah.
No, it's not organic lah. It's not organic. It's usually is foreign material, and then you connect the two lah, pulmonary artery and also the subclavian artery.
Oh, okay, alright. Thank you.
That's what we call modified BT shunt. I think everywhere you go now they use modified BT shunt. They rarely, because you don't want to compromise the original artery lah. Okay.
Oh, okay.
Comments. Okay, good. Any other question ke? You guys boleh larat lagi ke ni? Kalau tak larat then kita ni lah postpone. Maybe next time kot. Ada banyak lagi ke? Kalau banyak lagi, sekejap let's see.
Ada lagi, 1, 2, 3, 4.
Banyak lagi.
Okay.
I suggest kita postpone for now. Maybe we can have another session. You guys decide lah when to continue the rest. Bila? Esok pun boleh. Esok tapi because tonight I'm going to travel to Kelantan. So esok. Esok boleh kot. Esok atau I mean during the weekend lah. During the weekend ataupun Sunday pun I'm quite free. Monday, to be honest, I'm quite free most of the time lah because I punya kerja sekarang is teaching and also do research. So I'm doing my proposal at the moment. So but the rest of the time kalau I tak ada class, I memang quite free. So kalau you nak lah, then you guys decide and then arrange another time for the other for presentation. Because I'm going to also present the management of that spell kan. That's one of the ILOs. Okay. Ada soalan? Ada kan? So okay lah, setuju tak? Ke you guys nak present tak? Pukul 3 I ada meeting. So and I bejak mak pun.
Okay je,
Alright, Dato'.
Postpone
Okay je.
Cuma sekejap, ada a few things I want to mention here. In general kan, congenital heart disease, we are talking about structural heart disease kan. Okay, so congenital heart disease can be divided into cyanotic, acyanotic. Okay, or it can be divided, the cyanotic usually you divide critical cyanotic heart, complex cyanotic heart ataupun non-complex cyanotic heart. Complex cyanotic heart means cyanotic heart disease that have to be corrected within the first year of life. That's what you call complex cyanotic heart. Okay, faham? Yang non-complex ni you can wait lah. You can do palliative surgery and you can wait. Okay, and a lot of these children, the problem with heart disease, especially complex cyanotic heart disease, is they don't appear at birth. Okay, a lot of heart disease they don't appear at birth. Okay, those septal defect kan, they don't appear at birth. You won't detect them at birth unless you do echo atau because for example lah PDA kan, you won't hear murmur at birth. Okay, murmur you won't hear at birth. The only murmur that you can hear at birth are usually murmur of the valve punya problem. Kalau ada valve punya problem macam TOF, you boleh dengar murmur at birth because dia ada PS. Okay, kalau patient ni ada aortic stenosis, ada mitral regurg, you dengar murmur at birth. Tapi ada murmur kan, macam VSD punya murmur, ASD punya murmur, PDA punya murmur, you won't hear this murmur at birth. Okay, and all the cyanotic heart, most of the time they don't get sinus until the PDA close. Okay, because PDA will always helps to divert blood to the lung kan. So rarely divert sinus lah. Okay, lepas tu satu. Second is so a lot of these children, a lot of these baby, they will appear, those with acyanotic heart, macam septal defect, they will appear at the age of 4 to 6 weeks. Tahu kan? Because that's when the time of pulmonary pressure reduce. So a lot of them, the symptoms simple je. Symptoms of heart disease is, the main symptom is either sinus ataupun breathless. Ataupun mati ataupun syncope lah. Mati, syncope atau palpitation. Tapi in general congenital heart disease, the main presentation is failure symptoms ataupun cyanosis. Okay. Kalau those yang without cyanotic heart, acyanotic heart disease, they will only get failure symptoms if the significant amount of blood delivered to the lung. Okay, faham tak? Bila banyak sangat blood dalam lung, baru dia orang jadi breathless. Kan I mention just now kan? Bila sikit blood dalam lung, dia tak breathless lah. Okay. So, because baby dia born dengan pulmonary hypertension, these are protective to the lung. So, tak banyak darah boleh pergi kat lung. Because dia ada pulmonary hypertension. Tapi as the baby grows, between 4 to 6 weeks, this is when the pulmonary hypertension will resolve. Will reduce to the normal amount lah, macam normal value to like adultnya pulmonary hypertension, pulmonary pressure. So this is when they've got the failure symptoms. Okay, faham kan? So those acyanotic heart, they usually presented at between 4 to 6 weeks, and those yang cyanotic heart, they usually presented after PDA closure fully, usually about 1 week of life. For 5 days to 1 week of life. Okay. Usually that time lah. And kalau dia datang lambat lagi, dia akan datang dengan sama ada datang dengan death ataupun datang dengan cardiogenic shock ataupun dia datang dengan hypercyanotic spell. Macam TOF kan, TOF most of time kita diagnose TOF at the age of once dia aktif. Bila dia aktif, dia akan dapatlah hypercyanotic spell. That is when you diagnose TOF. Because it's very difficult to recognize cyanosis. The cyanosis is not easy to recognize lah. Okay, itu cukup. Ada last soalan before we stop?
Sorry Doktor, yang postpone class tu, is it okay for next week Doktor? Because this weekend ada macam prime.
Okay. Kalau next week, sekejap. Sekejap check. Next week, on the 21st, kita tak ada apa-apa. 22nd, I ada kelas pagi. So 22nd petang boleh lah, 22nd petang boleh.
Petang.
23rd, I'm free the whole day. 23rd tu I punya anniversary tapi I rasa I free je. So 24th memang I full. 24th je yang memang penuh. 22nd petang free.
Dengan
Yang rest semua tak ada apa-apa.
22nd petang dengan 23rd kan Doktor?
Dengan 25th, 26th.
Okay.
So nanti you guys discuss and decide lah.
Okay, alright.
Okay. Okay, kita tanggungan tasbih kafarah. Astagfirullah. Assalamualaikum warahmatullahi wabarakatuh.
Thank you Doktor.
Thank you Doktor.
Gambar bagi.